I want to introduce Amber Haselberger. And I said, oh yeah. And Amber is with Lifespark Hospice. And this is a program that we've kind of talked about in our Tuesday program committee. It's something that I think all of us have dealt with, or maybe we haven't yet, but we have questions about. And we thought this is just a great opportunity for us to learn more about hospice, and in connection with some of the other programs that we've been doing this year. So please give a warm welcome to Amber.
I'm a little bit taller than with my shoes on here. Well, thank you, everybody. It's lovely being here, I have to say. I have never been so welcomed at any speaking event I've ever done. The building's beautiful, you all are wonderful, so thank you. And you can hear me okay, right? You all can hear me, okay. My parents were teachers, former teachers, so I said I don't really need a mic. My voice projects. I grew up with parents who were teachers, so I will try to tone it down a little bit. But I am with Lifespark Health. How many, I'm just curious, have any of you heard of Lifespark? No, a few of you? Okay. We are, the way I describe Lifespark, we are a kind of a whole person-centered company. I know that you hear a lot about person-centered care in healthcare, but Lifespark has many service lines. Hospice is one of them. With Lifespark Hospice, we've only been around, I would say, for a little under 3 years. We provide a lot of other services like skilled therapies and private pay home care, but hospice is fairly new. And I was asked to come and speak today, and I love to speak to hospice. I hear a lot of, I heard a lot of chatter saying, I don't really need this quite yet, but I'm here to learn. And hospice is something, you never know when you're going to need it, right? None of us have a crystal ball in our hands. And so my job with Lifespark, I am a clinical liaison. So I am a social worker of about 22 years. I've only worked in geriatrics, which is kind of unheard of from the social work world. We tend to kind of hop around a lot, but I really like what I do. And so I've been doing this quite a while, so they like to send me out to speak to it because I love to speak to hospice. So thank you again. The way I describe hospice is probably a little different than a lot of you have heard. Hospice kind of has a bad rap out there. I think it's safe to say. I sometimes wish I could take that word hospice and just either rename it or put it somewhere where we don't see the word, because when we look at that word, it has kind of a negative connotation to it. It kind of gives you that, oh, kind of feeling. But hospice is so wonderful, and it's probably one of the most underutilized benefits. Like I said, if I could take that word and just show everybody what's under that benefit, most people would say, yep, sign me up. But when you see that word, it's just a little scary, so that's why I like to speak to it. Part of what I do is I go around the city and I speak to hospice and kind of try to dispel some of the myths, because it's changed quite a bit over the years. So we'll start. We'll get going here. I could stand up here and just talk all day, you guys. And there will be time for questions afterwards as well. And I am an open book, so feel free to ask me anything. No question is a dumb question or an unreasonable one, so feel free. I always like to start out with this, especially because I'm sure a lot of you have seen Jimmy Carter in the news lately too as well. He just entered hospice care. But this quote is by his wife. It says, "There are 4 kinds of people in this world. Those who have been caregivers, those who are currently caregivers, those who will become caregivers, and those who need caregivers." That's a pretty powerful quote. I have a little plaque above my sink at home, and it says, "Live a great story." It's pretty powerful. I look at that every morning before I come to work, because I talk about death and dying all day, every day to people. That's my job. And so I have to remember when I go out in the morning, people's story is not over yet, just because they enter hospice care. In fact, we like to say their stories, it's just beginning. we're bringing out a lot of what their story was and what it is. I think sometimes, again, we think hospice and we think, death. That's what hospice means, is death. But for those of us that work in hospice care, it's actually about life, and it's about living life. And how do we manifest hope still within our hospice patients? So I just put these up there, and some of this stuff, you guys, I give a lot of talks to healthcare professionals, so some of this might skip over sometimes because it might not necessarily apply to you guys, but these are just kind of the learning objectives that I put in here as to kind of what I'm going to speak to today. And I do have copies of this presentation, and I can absolutely email them out to Nadine if you guys want a copy of this. I'll send her a copy so that you have it. But we're going to talk a little bit about kind of what is hospice. It's part of the Medicare benefit, so we'll talk about that. We'll talk about if you wanted to refer somebody to me for hospice services, or if you have a family member or a friend, or yourself, and you'd like to know more about it. We'll talk about kind of how you qualify for hospice, because like I said, it's changed quite a bit over the years. And then identify questions to kind of talk about, with your family, what is hospice? How do we identify when someone's ready for hospice? Is hospice a scary word? I often ask people, if I went to speak at a conference and I said, if I asked you what your favorite car is, and I told you it was free, everything that you want, fully loaded, beautiful car, would you take it? Everybody said yes, of course. Well, that's what hospice is. It is a free benefit under Medicare that if you're found eligible for, is at no cost to you. It's an amazing benefit, hospice is. And like I said, it's probably one of the most underutilized benefits because it's scary. Hospice is that scary word. And why? We often ask ourselves why. And we see hospice in the movies, we read about hospice, we might have family members that had a poor experience with hospice in the past. I always say, hospice, across the board, you have different hospice companies. That's kind of the shell. We all have to operate under the same guidelines, but it's the people under that hospice program that make hospice, right? We call those people true hospice workers. There's some of us that find it as a calling to work in hospice, and then, sometimes people might just see it kind of as another job, right? But for those of us that see it as a calling, we call them true hospice. So we love hospice and love to speak to it. So what is hospice? It's defined as a program that provides support and care for people in the last phases of an incurable disease so that they may live fully and as comfortably as possible. So if your disease ran its normal course, you might qualify for hospice. And I put some of these slides on just for history purposes. So these are the origins of modern hospice. Hospice was actually one of the first origins was nuns in the Catholic Church that provided hospice. So we had lots of different forms of hospice, people taking care of people. But in 1983, it was actually recognized as a Medicare benefit. So not that long ago, actually, when you think about it, wasn't that long ago. So what do most people wish for in their late life? To be cared for with dignity and respect, to have family members and loved ones close by, to be comfortable and free of pain, and have control over their health care. So I like to say hospice kind of takes the liability away. We come in with all this goodness that we're sprinkling around, and we kind of take that liability away from people. We have, people that might be diabetic that say, I want to eat chocolate cake. Eat the chocolate cake. You're under hospice care, right? We talk to people about what do they want to see in their last days of life? What's meaningful to them? How can we bring meaning to their last days? These are some common hospice myths. And I like to talk about these a little bit because it's our job to kind of go out and dispel some of these. So hospice is a place. We can come to wherever you call home. We have homeless population that we serve under hospice care. So whatever you call home, we can come to. A care facility can provide hospice care. So assisted livings, I think that's a common myth, is when we go into assisted livings or nursing homes, a lot of times it's confusing for people because they say to us, well, who's providing the care, right? If you live in an assisted living or a nursing home, your care in that facility doesn't change. We're just adding to that care. So our team is coming in and working together with that team to add care. Hospice means giving up. It's quite the opposite. There's been so many studies done, and it actually shows that people that enroll in hospice when they're first eligible actually live 6 months to a year longer than people who don't. And the reason for that is because we're providing symptom management. We're providing very good symptom management so people feel good, right? The hospice Medicare benefit lasts only 6 months. I think that is the biggest misconception that I hear out there is, you know, I just went to see a gentleman yesterday and I walked in and he said, so you're telling me I'm not gonna be here, he said, in 6 months. Quite the contrary, actually. My longest hospice patient was 8 years on hospice. And we'll kind of talk about why that is in a little bit. But no, essentially the way Medicare defines it as if you know, you passed away within that 6 month period, you know, would that be a surprise due to your terminal illness? Probably not, right? But as long as you're showing that general decline, you could still qualify for hospice services. So it's our job as clinicians to show that you are still in that decline of your terminal illness and you could still qualify for hospice. So you just keep recertifying, and we'll kind of talk about that in a little bit. But yes, you can be on hospice longer than 6 months. A client must be a DNR status. So what that means is, when you go to the doctor, I don't know a lot of how familiar you guys are with this, but they will have you fill out a post, they call it sometimes, which is a physician's order, and you're indicating if you want to be full code, which is full resuscitation, or you want to be a DNR status, which is do not resuscitate or comfort care. We do bring patients onto hospice who are full code, which means they want to be fully resuscitated. That's okay. You do not have to be a DNR status to be on hospice. Do we have conversations about that at a later time? Yes, we do. But it does not disqualify you from being on hospice. And I think that's one of the biggest myths that I hear out there. You must stop all treatments. I think that's another big one. People assume that we come in and we just start taking everything away, taking medications away, you know, telling you what you can and cannot do. And it's quite the opposite. We're just adding. Down the line, as your illness progresses, yes, we might have conversations about your medications and things like that, but that is because those medications might not be doing something for your body anymore as they once have. But we do not come in and take things away. We're adding just a lot of goodness to your days. And the client must be actively dying. Like I said, no, my longest patient was 8 years. So I don't know how, if this is really applicable to you guys, but I put this in here just because it kind of shows, and we haven't added all the other years here yet, but kind of the total number of days on hospice. So the average length of stay, you can see right there, it says 86.7 to 92.6. Our goal as hospice clinicians is to get people on hospice as soon as they're eligible. A lot of us have advocated at the Capitol, we've advocated to reps, we've said, you know what, it's a wonderful benefit and we're getting people too late in their disease process. We want them earlier in that disease process so that we can provide support to them and their families. Being with people in the last weeks of life serve their purpose, but really getting to know them and building those relationships early on are so important. And this this talks about the payer source. So obviously a majority of it is Medicare because we serve people 55 and older at Lifespark. Not saying that there isn't, you know, pediatric hospice and things like that, but at Lifespark we just serve 55 and older. So what is the Medicare hospice benefit? It is, the beneficiaries are people age 65 or older. So your Part A benefit, right now, it covers your skilled therapies. So if you needed PT, OT, speech therapy, those types of therapies, it also covers if you had to go to, let's say you had surgery and you had to go to a transitional care unit and have rehab. So your Part A benefit covers the rehab facility. It covers home health care in your home. So when you come back from that rehab facility, will you need more physical therapy and things? It covers that. It also covers hospice care. You can only use one of these benefits at a time. So when I go and see families, if they're entering hospice care, they cannot go to the hospital without it being directed by hospice. You can no longer use those therapies if you're under hospice care, because your Part A benefit can only cover one thing at a time, okay? So I like to say there's pools, right? So you can't dip into each pool at the same time, you can only use one at a time. So the way I kind of describe it to families is if you are saying that you want to enter hospice care, what you're telling me is I no longer want to seek curable treatment for that disease process. I no longer want to sit in the ER, right? Going back and forth from the ER and recanting your story over and over to different doctors. And I no longer want therapies. I just want to remain comfortable in my own home. The Hospice Bill of Rights. I stuck this in here because a lot of you probably don't know that there's a Bill of Rights. When you go to the hospital, they hand you a Bill of Rights. When you sign up for hospice, they hand you a Bill of Rights. Once you sign up for hospice, you can change to a different hospice once every certification period. So if you signed up with Lifespark Hospice and you weren't happy, which doesn't happen very often, but if you weren't, you could sign up with a different hospice. There's certain rights under hospice that all companies have to abide by. So you can change hospice providers once every cert period. You can also cancel hospice at any time. So a lot of people get scared to sign up for hospice because they think, I'm signing on this dotted line and that's it. Now I'm under hospice. You can revoke hospice at any time. So what does it actually provide? Late life care that focuses on comfort and quality of life. So the hospice benefit itself covers a whole disciplinary team. If you have someone that you feel would benefit from hospice, what we usually recommend is to give us a call. Someone like me is going to come out and kind of talk a little bit about hospice and kind of just what's going on, right? Kind of painting that picture over the last 6 months. What's changed over the last 6 months to a year? A lot of people are very surprised that they qualify for hospice, I'll be honest. Because again, people assume that people under hospice care are actively dying, that they're bedridden. Not that they're driving to Cub Foods to get groceries still, right? Or they're doing some of those things. And so I think people are surprised that they might qualify for hospice, but someone like me is going to come out and talk to you a little bit about it and what the benefit is and get to know you a little bit. Not your disease, you, who you are as a person. We all come with different life experiences and memories and pain and everything else, and those things have to be explored too. So we don't come out just to learn about your disease process, we're actually coming out to learn about you. And if after that meeting, if you're interested in hospice, we would send a nurse out to see if you qualified for hospice. You need 2 medical directors to kind of give that okay. It's one is your doctor, and then the other is our hospice medical director that has to approve that. And then you enter hospice care. So what's covered under that benefit, you have a whole team. You have a nurse assigned to you, an RN that's assigned to you, and her nurse frequency is really dependent on how you're presenting, symptom-wise. So those nursing visits can go anywhere from 1 to 7 days a week. You have availability to that nursing staff 24 hours a day. So if it's 2 a.m. and it's a rough night, you can give us a call and we'd send the nurse out right away. You would have a social worker on your team. You'd have things like music therapy, massage therapy. All of those interdisciplinary members are so important for pain and symptom control, not just the nursing, right? We talk a lot about nursing and medications and things, but Music therapy, massage therapy, we have seen do amazing things when they work hand in hand with nursing. Medical equipment. All of your medical equipment and medication is covered under the hospice benefit, as well as incontinence supplies. Everything is covered in relation to your comfort. So I just put something on here. It says benefits of hospice, palliative care. I think these two words, hospice and palliative care, get used quite interchangeably, and they're confusing for people. Palliative care, we hear a lot of people use it when they're talking about hospice, but when you go under palliative care, it's still comfort focused, but you're still seeking treatment for your illness. So you'll hear your doctor talk a lot about, palliative care. You're still seeking curative treatment for whatever you're battling, but it's still comfort focused. Hospice is when you're no longer seeking treatment for that illness. One-on-one emotional support. This I cannot say enough of. When that nurse is coming out to see you, she's really teaching and training too. And so she is, I like to say you have doctors of pulmonology, cardiac, all these different specialties. Well, hospice, we are kind of the doctors of pain and comfort, of symptom management. We know the secret sauce, so to speak. And those nurses know those illnesses very, very well, and they can teach and train and explain what's going on with your loved one in different ways. And so that's what hospice is all about. Financial relief. I think I mentioned, all medical equipment is covered under that benefit. Medications are covered. And then no more trips to the ER. In the Midwest, especially, I like to say we are very, I'm from North Dakota, so we bring hot dishes to people and they don't feel well. But we're very treatment focused in society, right? More therapy, more food. If we can just get them to eat one more meal, let's try one more round of therapy, all of those things. What we don't realize though, is that sometimes those things can do more harm than good. Sometimes our bodies are so tired that pumping them with food and therapy and everything, we're actually deconditioning someone even more so than just allowing their body to just be, right, and be comfortable. And this just goes over kind of what I just described. So this is the whole team under hospice. Your hospice medical director, you can keep your primary doctor if you're on hospice, or you can change to our medical director as your primary. We have nurse practitioners on our team, nurses, social workers, chaplains. We have hospice aides, volunteers, and therapists. So you have this whole team that comes out to you. We talked about the equipment and medications and supplies. What we have at Lifespark, though, that is kind of unique, is because we have a skilled side, we have therapies like physical therapy and occupational and speech, we can pull from those therapies sometimes for consults for our hospice patients if needed. Not saying that they would complete those therapies, but let's say somebody was walking at one time and now they're in the wheelchair, and we're having difficulty transferring them, right, from the wheelchair to the bed. We might pull one of our physical therapists in to do a consult at no charge to the family. We just kind of eat that cost. And so a lot of hospice agencies don't have that luxury to do that because they don't have that in-house, but we do. And bereavement services. Our bereavement coordinator is a social worker by background of 30 years, and she follows our families for 13 months after somebody passes. And when I say follows, it's not just a phone call. She's made home visits, she's taken people for lunch, for coffee, she's really made meaningful relationships with those families and kind of helping them through that grief process. And this is that slide. And staff. For those of us that work in hospice, it affects staff too. We get close to our patients and families. And so we do bereavement services for our staff. We do them for assisted livings and nursing homes, for hospitals, whatever we can do to support people that care for your loved ones. So who is eligible to receive hospice care? Like I said, it needs to be recognized by 2 doctors. So typically, we would get what we call an order from your primary physician that says, yep, I think that she or he is ready for hospice care or is eligible for hospice. And then, like I mentioned before, we'd send our nurse out and myself to determine if you were eligible for hospice. I like to say hospice is kind of two parts. You could qualify for it under Medicare, but it's also a philosophy of care. And so your body might be saying, I'm tired, but your mind is something else. So if you're not ready for hospice care or you are not aligned with the philosophy, you may not sign up for hospice care. But part of that is, again, it's the education piece. So it's me coming out to talk to you about what are your goals for your health care? What do you still want to pursue those treatments? We kind of go into a lot of depth on that and what that means to people. We talk about quality of life versus quantity of life. We talk with your family. So a lot of these are ongoing discussions that we have with people. And I like to say, I don't wear it lightly on my shoulders when I go in and talk with patients and families. It's not just a conversation to me. A lot of times the conversations in the hospitals can be very quick because they're very busy. They don't get to sit down with people and have these long conversations. And so they send people in like me that can take 2 to 4 hours out of an afternoon to sit down and talk with you. They're very important conversations. A lot of people have exhausted all treatments, and you are kind of their last line. And so they're really looking to you for that, and so we don't really wear those conversations lightly. And I just put this in here just for kind of some info. It just gives kind of the top 7 leading causes of natural death, with heart disease as being number 1. People are often surprised we have Alzheimer's disease in here, and I think, in society, we see in the news, we have, all the Alzheimer's walks and everything. We have normalized memory loss to a certain extent. It is not a normal part of aging. Memory loss is not. I like to say, the dementias and Alzheimer's, it's failure of the brain. It is still a terminal diagnosis that we can bring someone onto hospice with. But I like to point that one out because I usually get kind of some stares when I talk about that one. But like I said, I think we've just normalized it. So hospice triggers. What might trigger a hospice referral by your physician? A noted decline in functional ability. So I like to say, was that person maybe walking and now they're in the wheelchair? Were they able to bathe and feed themselves and now they're not? Any significant decline in somebody may trigger a hospice referral if they have a terminal diagnosis. A weight loss is huge if they have a 10% weight loss in 6 months. And that can be misleading as well, because a lot of times we'll talk about, fluid retention. We see a lot of fluid retention in patients. So that one can be tricky. Recurrent infections, UTIs, pneumonia, are they in and out of the ER constantly? Are we going back and forth from the ER? Are they clearing those infections? Are they resurfacing? Short of breath. If someone is on oxygen and they're sitting in their chair there, and I'm noticing that they're still short of breath, right? They can't do much without being short of breath. And then lack of progress in therapies, the PT and the OT. I keep hearing, let's do one more round, Amber. Let's do one more round. So caring for the hospice patient. Comfort covers more than pain, and we say this a lot when we go out. We're not just managing their pain and comfort, we're managing their grief and their loss. It's a series of losses, right? Life is a series of losses. And that's where some of those other therapies kind of come into play. Our chaplain, our social worker, we all work as a team. And I'm gonna skip that one. Okay, cues. Some of these are just some common things that we hear as clinicians a lot. I'm tired of this. I don't want to go back to the hospital anymore. I'm sick of telling my story to every new doctor when I go to the ER. I don't want to continue treatment. I'm ready to go. They bring up a lot of maybe religious type background conversations. I don't want to be a burden. I have nothing to live for. All of my friends and family are gone. I want to be with my spouse. I just want to die, or I want to make the most of the time I have left. So those are some common phrases that we hear as clinicians. You know, a lot of people ask me, Amber, how do I have the conversation with my family? How do I do that? You know, they're not wanting to do that with me. Like I said, a lot of it is ongoing. So we don't walk into people's homes and just say, okay, I'm here to talk about hospice. It usually doesn't go over well like that. We walk in, and like I said, it's ongoing. So a lot of my first conversations with people, if they're not at that level of acceptance, is just getting to know them as people and connecting with them. So that connection is really, really important, and making sure that they understand the purpose of the conversation. Because again, we're talking about something that none of us have experienced. None of us have died before. So who am I, right, to walk in and say, okay, let's talk about this, right? I've never died before. I don't know what that's going to be like. So I'm coming in with empathy and compassion and finding out what they want. I think that's the one thing too, is they're going through multiple physicians. You know, they're almost like a chart number at that point in their minds. And so when I walk in to talk to a family, they're kind of looking at me like, well, what do you want, right? I've already talked to a million of you. What do you want? So it's really connecting with them as people. We do a lot of consults, and that's what this kind of talks about. So a lot of people sometimes aren't just ready to admit to hospice right away. So we do a lot of consults, and that's where I go out and I meet with families and we just talk about hospice. Initiating the hospice conversation earlier is always better. I wish that they didn't wait to talk about hospice until someone had a terminal diagnosis. Like I said, in society, I think it's just a scary word, but normalizing it a little bit and understanding what it is, so if that time comes, you've already had that talk, right? You already understand it. It's a lot harder to make decisions in crisis mode rather than just getting the information early on. But having a consult does not mean that you automatically qualify for hospice. It's more so just like an informational session. And then making a referral to us. So if you have somebody that's interested in hospice care, you just give us a call. You know, a lot of this is stuff that we would get, but just give us a call if you've noticed any changes in your loved one. Like I said, it does not mean that they're going to pass away a week from now, or 2 weeks from now, or 6 months from now. It's merely you're saying, you know, I want to put some care in place. It's almost like another service, is what we say. It's not the end. We're just adding more to their daily life, is what we're doing. We're adding meaning to their daily life. So what to expect with hospice. Once you enter hospice, communication. So our whole team is communicating with you on a daily basis. Individualized plans of care. So like I said, we can come right to your home and provide hospice. We can provide hospice in any assisted living, any nursing home. We're really partnering with that facility, and they're really looking to us for guidance on how to care for somebody at end of life. We are making sure that your needs are met, education and instruction, so we do a lot of teaching of staff in different buildings. Scheduled visits. A death visit. The reason I put this up there is Medicare does not require, when somebody passes away under hospice, they do not require that hospice agency to go out at the time of death. It's bizarre, isn't it? I mean, we're with family the whole time under hospice. Why wouldn't we go out when somebody passes? But Medicare says that that's not a requirement. So there are some hospice agencies that will not go out when somebody passes if they're in a facility, because they assume that there's nurses in those facilities. we always go out. We always go out at Lifespark Hospice when somebody passes, because again, that is such an important moment. You have made relationships with that person, you have made relationships with the family. It is our job to be there at that time. So when we do go out on a death visit, we are doing things like calling family for you if needed. We're calling the funeral home. We are being there for grief and support. A lot of our clinicians, our chaplain, our therapists, they will come also. And so again, it's a whole team approach. And that's all I have for you today. Do you guys have any questions? Yeah?
Is this hospice care unique to Minnesota, or is it all over the country? Because my husband's sister is ready from us, she's 93 and lives in St. Louis, and they're struggling with what to do for her. So.
Yes, it's across the country. It's across the country. So there's different types of hospice, and I can explain this. There's something called routine home care, and that's traditional hospice. That's 90% of hospice across the United States. That's where we come to you. It's called routine home care, but yes, it's universal throughout the United States. Now, like I said, some hospices are going to all operate a little bit differently, but we all have the same regulations that we have to follow. So some hospices, I always say interview more than one. Don't just interview one. And a lot of times they're gonna send out their sales reps for those interviews. So always ask who you have the interview with, and even ask, could I meet one of your nurses from your agency to come out and do the interview? Ask what they provide, because a lot of those services, like the chaplain, the music therapist, the massage therapist, those are not required under that benefit, and so some hospices do not have those. So you might just get the nurse that comes out, which is fine, but a lot of people want those ancillary services to help in that provision of care. And so ask those questions. And I actually have a list of questions that I can send Nadine if you guys would like them. And they're just good questions to ask if you're interviewing hospice agencies, to ask them. Because a lot of people don't know what to ask, right? Because they've never gone through it. So I have a list, though. I can email her out for you. Yeah.
You had talked about how people become eligible for hospice. Could you review how you become eligible for palliative care?
So like I mentioned, palliative and hospice, palliative care, they're like on opposite sides of the spectrum a little bit. Palliative care in this community, in the Twin Cities, I don't want to say it's new, because it's obviously not new, but it's not as recognized or utilized, I think, in the community setting as much, if that makes any sense. Palliative care is comfort. So if your doctor says, I think I'm going to put you under palliative care, what he or she is saying is comfort-focused treatment. So the care plan is comfort-focused. So not a lot of invasive treatments anymore at that point. But it's essentially saying that all of your clinical providers are going to be under comfort-focused direction. There are some providers in the Twin Cities that will come to your home for palliative care visits. Some insurance companies will cover it. It's not like hospice, I will say that. You're only designated typically so many nursing visits per year, and I want to say some of them are like once a month. There might have changed a little bit, but you're still seeking cures. You're still seeking medications and therapies for your illness, but it's comfort focused. So it's a little confusing, but what you're basically saying is you do not want any invasive treatments. It's still a term that when we have meetings, a lot of even physicians and stuff say, well, what does this even mean? What are, basically we're notifying all of your providers that you want comfort-focused treatment only, is what that is. Yeah. Hospice, like I said, you're no longer seeking those treatments. So you just want to be comfortable at home and remain at home. There are different diagnoses under the Medicare benefit that would qualify you for hospice, and what happens is they look at that diagnosis and they see, are you displaying any of those symptoms under that diagnosis that might qualify you for hospice. So it's up to that nurse to kind of paint the picture for that hospice director. Do you qualify under that diagnosis? Yes.
So, as somebody that's kind of visited a lot of people in long-term care facilities and things, it feels like there are more people that would benefit in some of those facilities.
Yes.
So, I mean, how is that is that changing? Is
Mm-hmm.
that, how could that change?
Yeah, that's a good point. So part of my job, I no longer practice social work per se. I don't have a caseload where I'm going out to see patients. A lot of what I do is I go into facilities and I try to educate staff in those facilities about what might prompt a hospice referral. We have a lot of meetings with a lot of nursing homes and assisted livings where we sit in on those meetings and they go over a lot of their residents in there, and they talk about, so-and-so went to the hospital, this is his 4th hospital trip, in 6 months, this is what's happening, this is what we're seeing in this client, So a lot of what I do is education. So I'm going out and I'm meeting with nurses and home health aides in these buildings and saying, with a census, let's say a nursing home of like 85, there should be more than 2 people, we would think, in your nursing home that would qualify for hospice. And really getting people to understand, like I said, it's a benefit that they have earned, that they deserve to use. What we find a lot of times as hospice clinicians is a lot of people don't like to have the conversation with people, and we always say just kind of throw the towel over, let us do that. We just really need the name and the family, and we can do that. We can take that off their plate and have those conversations because that's what we're trained to do. But a lot of it we're finding is just the education, the lack of education behind it, and the understanding, and just the fear sometimes of initiating that hospice conversation with the family. Or they've had the conversation and family is not on board. Because again, it's that big scary word that we don't want to talk about. And a lot of people think, well, if we bring hospice, that's going to make them die quicker, because they have hospice. Us being on board will not make the illness progress any faster, just like, not having hospice will keep you alive longer. So, but yes, there is, I cannot tell you, I am in probably 5 buildings a day in the metro, just trying to identify resources for staff and provide education. So we've come a long way in hospice, but it is still such a need for education in the community. We do a lot in churches, we do a lot at like YWCAs too. We try to just get the word out there. I always say I could get in a car accident today, right? I could be diagnosed with something today too. So hospice is not just for people in their 80s and 90s. I think that's the misconception is I don't need hospice. I'm never gonna need hospice. I won't need hospice for 50 more years, right? But we don't know. None of us have a crystal ball.
Can you tell us how qualification for hospice occurs with dementia?
Sure. Dementia, I would say, is probably the trickiest. And the reason for that is, like I said, I call it failure of the brain, because we have a lot of families that say, well, no, mom's just having trouble. Like and I always say, well, that's not normal, right? When you're aging, dementia is not a normal part of aging. So something either acute happened to cause that memory loss, but the dementias are probably the trickiest, and the reason for that is it's not like an illness like congestive heart failure, right? Where we kind of know somewhat of the trajectory of that illness, or cancers. Dementia, everybody progresses differently in that illness. Everybody's journey on that illness, it looks different. And it kind of reminds me of Parkinson's sometimes in a way, only because it has a lot of these hills and valleys. So some days you have really good days, right? Some days might not be such good days, so we call them peaks and valleys. So we get referrals a lot of times, and You know, they'll list down all of these things that have been happening, then we go out and it's a really good day, right? So we recognize that, so we might have to go out more than once just to see that person, just to kind of get an idea. But what we typically ask is, I always use this word, paint the picture. So tell me what's happened, what's changed in the last 6 months to a year. So with the dementias, what we're really looking for is, do they need assistance with their ADLs? So like walking, bathing, eating, are they needing more assistance with those? Swallowing is a big one with dementia. Do you notice that they're coughing? Are they coughing when they're eating or drinking? Are they having more difficulty swallowing? Weight loss is another big one. We talked about the weight loss, if there's been significant weight loss. Speech with dementia patients. I call it like nonsensical speech. Or, you know, if you're saying, how is your day today? And they're giving you more stereotypical responses, good. It's good. They're not going into detail. So a lot of stereotypical phrases, or aphasia, if they're, you know, if you're giving them an apple and they're calling it something else. There's a lot of indicators to us, multiple infections, so UTIs, pneumonia, all of those things. But the biggies are needing assistance with activities of daily living, the speech, the eating. So we're really looking for that sharp decline. So what we say is they were kind of doing this for a little while and then they kind of dipped like this. So they had some sharp decline in that illness is what we're looking for in hospice. And that's telling us that their disease process is progressing. You've heard people graduating off hospice sometimes. We don't like to do that. I'll tell you why. It's really hard to bring all this great stuff to people, all this wonderful support, and then you have to take it away if somebody graduates, and that's really hard for families. And dementia is probably, I'd say, probably the most common diagnosis that we probably graduate people off, and that's because, like I said, everybody's disease process with dementia is so different. So we might have noticed that sharp decline, brought them on with hospice, and then all of a sudden they perked up because we brought all this support in. And they're I don't want to say they're doing better, but we're managing their symptoms a lot better. So what happens under Medicare is we have to keep showing that decline in somebody under hospice to keep qualifying for hospice. It's our job to do that. We're so used to, as clinicians, charting goals, right? They walked so many feet, they ate this percent of their meal. Under hospice, we're doing the opposite. We're saying, well, they ate 40% of their meal as opposed to 80 last week. So we're really charting that decline in that illness. But people with dementia, a lot of times they plateau is what we say. So they kind of perk up and then there's no changes sometimes for months. We're not seeing any changes in the illness. So they might graduate off hospice at that point. If that decline then sets in after graduation, you can call us and we can bring them back on. But it's our job to show Medicare that their illness is still progressing. So it gets tricky.
If you're in hospice with dementia, can you still get care and hospitalization for congestive heart failure?
That's a good question. If you enter hospice,
Can you repeat that question?
yep. What she said is if you're under hospice for dementia, with a dementia diagnosis, can you still go to the hospital, did you say with heart failure? Is that with so if you come onto hospice, what you're telling us is you no longer want to treat things anymore. It does not mean, I say this kind of delicately because we're not saying that you can never use the hospital again. What we're saying is we're getting your Medicare dollars. So we get a daily benefit. So that Medicare Part A benefit's coming to us to pay for your team, to pay for your equipment, your medications, all of those things. So let's just say, I always use this example. Let's say somebody fell and they called the ambulance instead of calling us. Because once you're under hospice, we like to say we're the new 911. So instead of calling the ambulance, you call us. Because everything has to be directed by hospice in order for Medicare to pay for it. So if you sent someone into the hospital without it being directed by us, you would get a bill. That's why it's important to call hospice. But generally speaking, somebody that enters hospice would no longer be treating those other things as well at the hospital level, yeah.
You said you don't call calling 911 is almost like a knee-jerk reaction.
It is. You're right, it is. And I always clarify this, it's not that we don't use the hospital under hospice sometimes. There are reasons why we might send somebody maybe to the ER and back, like if they had a big head contusion, where we couldn't suture that right at their home, we might have to send them in. It's very rare that we have to do that, but again, it has to be directed by us, because we would pay for that visit. If that makes does that make sense?
How do you determine the number of hours that the individual receives per day? Or, I mean, is it ever 24/7
That's a
where
good
someone's
question.
in the home?
So hospice is not a 24/7 benefit, it's intermittent services. And so, care is really dependent a lot of times too as to where you live. So if you're living in your own home, you might see that nurse a lot more frequently just because there is no access to any other nursing staff, right? As opposed to somebody who's in a nursing home or an assisted living. Not saying that they wouldn't visit as frequently, but we use those nurses a lot of times as our eyes and ears. We trust family, obviously, but if you're not clinical, if you don't have a clinical background and you're not in a licensed facility, you might see us more in that home setting because of that. But it's really dependent on how they're presenting. And so, like I said, we just brought a patient onto hospice last night, and she's doing 5-day-a-week nursing visits right now because of how he's presenting symptom-wise. She wants to make sure she's there every day to check in. Now, if those symptoms subside and we get those under control, she might go down to 2 or 3 days a week to see him. So it's really dependent on how that person is presenting. But nursing, like I said, can be anywhere from 1 to 7 days a week. That nursing visit's typically an hour in length when they come. Now, sometimes people have pain that's not being managed. So let's say they're in an assisted living or home, and we get a call that says this person's in pain, they're not comfortable. We're going to go out and stay there until we know that their pain is being managed. We're not going to leave them until we know that they're comfortable. The social work, the chaplain, and all of those other therapies like music and massage, those are all typically 2 to 3 times a month, unless we see a benefit. So if somebody's benefiting from massage therapy, we can up that frequency. So it's really dependent on that person. We really design that care plan around that person. Does that answer your question?
I think so. I guess the other thing is you talk about managing their pain.
Mm-hmm.
Is that with drugs?
Yes,
Okay.
so we have something called a comfort pack that goes out to the home or the community. And in that comfort pack has all of the medications that we typically use under hospice. That's not excluding, what they typically are on normally. So whatever you're taking, daily or what have you. But we have something called a comfort pack. So what's in there is medications for pain, anxiety, anything that we're going to need. And sometimes we don't use those medications till very, very end of life. Sometimes we have to use some of those sooner, just kind of depending on how they're presenting.
That's all the time we have.
All right, yeah, well, thank
Thank
you guys.
you.
Yeah.
Thank you.